Thanks for joining us for today's special presentation. We are the Michigan Farm Institution Network, and today we're going to be talking about anchor institutions in action. We have two guest speakers. So I'll go ahead and introduce your hosts today. I am Mariel Borgman. I am an MSU Extension Community Food Systems educator, part of the MIFIN Tech Ed subcommittee, and my co-host is Caitlin Wojak, also with MSU Extension Community Food Systems and part of the MIFIN Tech Ed subcommittee. So we have two amazing guest speakers to share with you today. They are going to be joining us here in just a few minutes. I wanted to quickly just address a few logistical things. So if those participating on Zoom with a video capability would not mind turning off your video, that might help to eliminate some distractions from the speakers today. And as you have questions that come up during this presentation today, if you could put those in the chat box as they come up at any time, and then we'll get those addressed at the end of the presentation. So without further ado, our guest speakers today, we have David Zuckerman joining us, and David is the Director of Healthcare Engagement for the Democracy Collaborative. He leads the team that coordinates the Healthcare Anchor Network, a health system-led collaboration focused on improving community health and well-being by building inclusive and sustainable local economies. The network includes more than 40 health systems to date. And we also have Sarah Chartier, who is based in Michigan, and she's the Senior Sustainability Project Manager with Spectrum Health Services. We here at MIFIN have connected with Sarah over the years, primarily through her engagement in the Michigan Green Healthcare Committee. So we at MIFIN always like to seek and learn more about new approaches to institutional food purchasing, and the focus of today's presentation on anchor institutions is just that. So I would like to turn it over to our first speaker, David Zuckerman, to talk about Healthcare Anchor Network. Take it away, David.
On the phone. So I'm going to walk through a couple of things here from our perspective at the Democracy Collaborative and the Healthcare Anchor Network, just sharing some definitions of how we think about anchor institutions and the opportunity, and then how that's evolved into the Healthcare Anchor Network, and also some other networks that include higher ed and what we're calling anchor collaboratives. So if we go to the next slide, I'll start by just sharing how we think of anchor institutions as nonprofit or public institutions. And we do think this ownership dimension is really important to take into consideration because it really impacts the opportunity for institutions to think longer term within their communities because of the relationships they might have, because of the investments they might have made in place, or because of simply the services they provide. And that as a result of this nonprofit or public arrangement, they tend to be much more rooted in place, what we call sticky capital. And what I think is also really important to just focus on for a moment is that in many ways, these very same organizations have become important economic engines within their communities over the last 30, 40 years, really growing and in some place supplanting traditional industry that might have had that role at some time. And therefore, there's a real opportunity to think differently about the role these organizations play in driving healthy communities. And in particular, I'm going to focus on that from the dimension of an inclusive economic development perspective, or what we call community wealth building. So on the next slide, if you think about it, a health system or a university or a local government, school system, a place-based foundation are anchor institutions by the definition that I just shared. Whether they take on this additional role is another question, and that's what we come to define as the anchor mission. This intentional process of leaning in and aligning resources both internally, so really creating that space for the conversation between different departments, as well as the opportunity to bring others along in the community that might not be so inclined to this perspective. And I think that's what is the power of this idea. For us, it matters, if you go to the next slide, because of the opportunity to really create an aligned strategy, especially as we operate in an era of increasingly scarce resources, It's not about spending more, it's about how do we leverage differently the resources we currently have to drive greater inclusive local growth. And that this is really, I think, as we think about it, at first, kind of getting your own internal house in order around alignment, and then thinking about the opportunity to set the stage and more broadly engage other partners around shared goals in the community. Next slide, please. For us, this is really important because of what we call community wealth building, which is an alternative approach to traditional economic development. I think we know the many stories of local governments, state governments trying to lure large businesses to communities with large incentives. Oftentimes, the return that we get from those large incentives that are taxpayer dollars for municipalities that are already resource scarce is not the gain we hope. And in many times, those same organizations or businesses might pick up and leave when those tax subsidies run out. So is there a different way to build from the strength and opportunities that we already have locally to align in a more powerful way? And that is really what we see as community wealth building. And in that process, building new models of local and shared ownership that we think is a nascent sector that hasn't really been explored in our country, but we can look around the country and see some innovative models, and I'll talk about one or two a little bit later here. Then there's also community development, individual asset building, which is a sector that has a long history in our country, but has often been under-resourced. And for us, the opportunity comes in connecting the dots more powerfully between the economic power that anchors have and have developed as they become large employers and purchasers, to both connect to existing community development infrastructure, but also more powerfully to lean into this opportunity around inclusive economic development and to build community wealth. Next slide. These are just some of the drivers that we think set community wealth building apart from traditional economic development. I won't go through all of them, but the ones that I think are most important to focus on are the first three: place, ownership, and multipliers, because I think the others are really critical: equity, workforce development, systems thinking, collaboration, but those do get called out in other models, as well as place. But what sets community wealth building apart is really this emphasis on ownership. How does what we invest in get owned broadly by the community? What is the opportunity for building wealth for disinvested communities where oftentimes there's investment in those communities, but residents don't benefit, or regions don't benefit? And to really think thoughtfully about multipliers. This is something that does underscore the local food movement, but that there is a real benefit from spending dollars locally with local businesses, that it circulates more quickly in the local economy and actually creates a net positive. And it's not actually a trade-off. It does actually create a net positive. Next slide. So why does all this matter? Why is it important for anchors to lean into this opportunity around community economic development? I'm going to speak most from the perspective of healthcare and healthy communities. I do think there are similar arguments to be made for why this matters to universities, local governments, and other anchors. But from the perspective of healthcare and those really interested in seeing healthy communities, we know that at the end of the day, what matters most is the social and economic factors in determining one's health outcomes, and that our tools for actually addressing the inequities that underlie economic inequality in our country are limited in the current fashion, and that we really need to think broadly about all of the resources we have in that endeavor. And that's really what's at the heart of the anchor mission approach. Next slide. And we see how these inequities can powerfully concentrate in place. This is a map of Cleveland. And I wish I could say that this story in Cleveland was unique to Cleveland and not other cities across the country. But unfortunately, this is the story of cities across America in which neighborhoods just a few miles apart are separated by 20 plus years in life expectancy. On the left, you have the Huff neighborhood, a predominantly low-income African-American community. On the right, you have Lyndhurst, a majority white affluent community. And why I put this slide versus other ones around the country is that here in particular, the Huff neighborhood is proximate to Cleveland Clinic and University hospitals, two world-renowned health systems that no one would dispute, but clearly the benefits of the healthcare system in terms of improving life expectancy and longevity are not spilling over into the adjacent neighborhood. Next slide. And the two previous slides around the inequities in place and the social determinants are ones that are increasingly becoming part of our conversation, which is really exciting to see. And it's sobering, but it's important that we're talking about them. I think another dimension that we think about as a democracy collaborative is the widening health and wealth gap in our country. And how, if you look back over 40 years, we're not seeing the improvements that we would hope from a country with such an abundance of resources as ours. And in addition to our efforts to end poverty stagnating, the racial wealth gap larger today than it was before the Great Recession, this really does translate into differences in lifespan outcomes between the wealthiest and poorest in our country, and having that double for men and triple for women over the last 40 years. And so as organizations, as institutions, as health systems, but anchors more broadly are caring about health and well-being in their communities, it begs the question of what can we all do to begin to shift these drivers? Next slide. For us, it's important to really focus on the economic assets that institutions have, that oftentimes we think about discretionary resources we can put into programming into the communities, and that's important, but that it will always pale in comparison to the bringing to bear the full strength of the organization through the everyday economic activities that it has. And that, for us, is really around workforce, supply chain, and leveraging long-term reserves. And that's really where we focus when we talk about place-based investment. So I'll just talk briefly about an example in each of these. And of course, I think what's important to take away from it is not how to copy the example, but how does the principle apply to how your institutions are showing up in communities, or how the institutions you want to partner with are showing up, and what might be a way to think, instead of about the needs, which I think from the healthcare perspective is something that healthcare is always focused on, community health needs, but to think about the assets that we have that can be more effectively leveraged and built upon in order to create a better foundation and stronger local economy. Next slide. So I'll talk briefly about inclusive local hiring, and I'll talk about the example of university hospitals. Next slide. We break down this area of the work into two themes, what we call outside in and inside up. And this is just to hopefully capture the big principles of what we're trying to convey with the idea of inclusive local hiring and internal workforce development. That the inside up piece is something that many institutions already do. They have thoughtful internal workforce development pipelines. We do see that many of them could be a little bit more seamless and connected better, but this is not in and of itself a new concept. On the other hand, thinking more intentionally about, are we actually creating a door into our institution from the neighborhoods that might have the highest health disparities, or the greatest levels of poverty or greatest level of disinvestment, is a bit of a newer approach, and we just term that as inclusive local hiring. But it's really not about drawing a circle around the institution and saying we're going to hire people from 1 mile away, but how are we actually creating opportunities for the neighborhoods that we serve or impact that might not have them? And then in that process, be thoughtful and intentional about connecting them to inside up strategies that will allow them to move from frontline positions to living wage jobs or family supporting jobs. Hopefully, most of the jobs are living wage to begin with. So university hospitals, will talk briefly about what they did around Step Up to the UH. And what you can see here is just they took pretty frontline positions and subdivided them even further in order to create a very intentional pathway for folks coming in the door from an environmental services, so not even within the medical field, to a medical assistant 3 over a period of years and promotions for those individuals. And they worked with a community-based organization to make that possible, as well as a workforce intermediary. So they didn't do everything themselves, but they leaned in to say, we want to be part of helping create this pipeline into our institution. And in particular, they focused on the neighborhood that I showed you earlier, the Huff neighborhood, that had the worst life expectancy in the entire county. Next slide. For inclusive local sourcing, purchasing for people in place, if we go to the next slide, there's 2 strategies or 2 ways we try to capture the opportunities here at a high level, which is creating connections to local existing vendors. So this might be prioritizing vendors that are within a certain geography, if we're thinking about local food purchasing, or it could be focused on recognizing that the vendor that can provide a certain good or service to your institution that you need might not exist, and thinking about who can be partnering with to build capacity, so that might be able to happen over time, creating new jobs within the community. Next slide. I'll talk briefly about Cleveland Clinic and University Hospitals, also back in that in the University Circle area that I highlighted on the earlier slide around life expectancy. And they've used a variety of strategies to try and be better at inclusive local sourcing. So I'll just touch on them at a high level, and I can go into more depth in the Q&A. The one that I want to call out in particular is one that the Democracy Collaborative is actually involved in helping get off the ground more than 10 years now, called the Evergreen Cooperatives. And I think the Evergreen Cooperatives tries to bring together the principles of anchor mission with community wealth building as best as possible. And the idea was, were there supply chain needs that could be sourced from the surrounding community if a new business was developed to meet that need? And could that business provide it at the cost and quality that the institutions would expect? Could it hire local? Could it pay a living wage? Could it provide health insurance? Could it be greenest in class? Could it be environmentally sustainable? And the additional wrinkle that we built into the model was, could it be employee owned? Could not only the residents in this community, in which the median area income was under $20,000, could they also share in the profits of that business if it was successful? And that became known as the Evergreen Cooperatives. And 10 years later, 200 people are employed by 3 different businesses, one of them being a commercial scale laundry, and the other being an urban greenhouse. And one of the biggest successes in this area just in the last year was that Cleveland Clinic moved its entire laundry operation to be operated by Evergreen Cooperatives, which is a really big win for this network of locally owned, community-owned, environmentally friendly businesses. Next slide. So the last area that I'll talk about is place-based investing. If we go to the next slide. If we think about this, the way we define it is really the opportunity for recognizing that large institutions have to hold long-term reserves. For the most part, those reserves sit in traditional stocks and bonds. Is there an opportunity to redirect a portion of that into the local economy that would be both fiduciary responsible, but also create, by creating a return, but also be an economic catalyst for projects that might be stuck locally? And so we do separate this terminology of place-based investment as different from just giving traditional grants, or how investment sometimes is used when we talk about projects in the community. Next slide. The example I want to talk about for here is Dignity Health. They are probably one of the leaders in the healthcare space around place-based investing. They've been doing it for decades, and they actually have said, we will take 5% of our long-term reserves for them as a health system. A university parallel might be the endowment, and say we're going to use that as a patient capital and projects with nonprofits that perhaps couldn't get traditional loans. We'll do the due diligence ourselves, and we'll take the bet that if we come in as a patient investor, that this project might be successful. So they're an outlier in the healthcare space in terms of doing all of that on their own. But other health systems have said, we'll work with intermediaries like community development financial institutions who can do that work for us, but we're still having the impact by bringing some of our resources locally. In this case, the slide you just previously saw was a children's museum that was basically a wandering museum. They were able to get this school for $1 from the city, but they couldn't raise the capital to build it out and rehab it. And Dignity came in with a loan, a several-year loan, and said, okay, we will make this investment. And because of Dignity making that bet, other more traditional lenders said, okay, we'll come in as well. And Dignity was paid back actually early in that process. And now you have a very successful children's museum in the city of Phoenix. Next slide. And it served as a catalyst for redevelopment in that part of the community as well. Secour has actually been a long leader around affordable housing and other types of investments in communities for well over 20 years. The specific dimension of their work that I want to call out is that they've been very thoughtful in thinking about, okay, we can do some of these loans, but sometimes it also needs grants. And as an organization that also provides grants, can we align the two? And in that way, that they were the first health system to intentionally invest in a community land trust in Richmond, Virginia, by aligning a low-interest loan with grants to get a project off the ground that otherwise would have been stuck. And it shows how they are responding to community need in a way that is different than necessarily assuming what is needed. But this was really through a community charrette process that said housing and the fear of gentrification in this part of the city was something that needed to be addressed. Next slide. So I'm not going to go through these slides in a lot of depth, but I want to share how these promising practices from across the country are starting to come together into a coherent strategy that we call the anchor mission approach, in which health systems are recognizing, and other anchors as well, but I'm going to speak specifically about health systems. Health systems are recognizing that they can do supply chain, they can do HR, they can do investment, they can do multiple strategies, and that together, if they were to lean in all of these strategies, that is where they'll have the most impact. This is just an example of how ProMedica is thinking about its anchor institution model and thinking about it as being one dimension, along with, of course, its role on clinical excellence and its effort to address social determinants. Next slide. Last year we put out a publication called the Anchor Mission Playbook. We worked in partnership with Rush University Medical Center on this, and it really documents their journey over just a year and a half to build out a strategy internally. And I think what's important about this resource is that it's a very much a nuts and bolts focus on the work. How do we actually create the structure inside our organization to make this work possible and to align it around a coherent strategy? If you go to the next slide, you'll see how they set targets in each of the core areas that I just articulated. And that was really the first time that an institution had framed it in this way and put out the goals that they had in each of these areas. And it's, I think, an important precedent for the field. And since then, we've seen other health systems really articulate how they are having multiple strategies that are going on in each of these areas. Next slide. In addition to this, they created several positions, but the one in particular that is important to call out was someone whose job it was to own this idea of alignment and helping the different business units in developing their strategies and how they might be more effective at leveraging their own internal resources. It wasn't necessarily realistic for Treasury to be out finding potential projects to make impact investments in, But through a partnership with this core team and through community engagement, there were tremendous resources across the institution that could be leveraged and effectively deployed at the right point in making those decisions ultimately. And they have made commitments around impact investment with the Chicago Community Loan Fund, which is a financial intermediary that invests on the west side of Chicago. Next slide. So all of this rolls up into the Healthcare Anchor Network, which is the network that I direct that seeks to support actually now more than 40 health systems in furthering their work in this area. You go to the next slide. So I just showed the purpose, again, to help systems more effectively advance this approach in their institutions. Next slide. And our goal is really to have this focus on the economic factors. We do have as an aspiration that we're leveraging all of our assets, and it's an aspiration. It's hard work. There are a lot of other competing priorities. But what is the opportunity to recognize that everything from the standing in the community to the government relations function to the back office support a large institution has can be leveraged to support either inclusive economic development or the capacity of nonprofits, et cetera, to be more effective within the community. Next slide. Go to the next one. Just briefly how we do our work. We seek to focus on trying to build the capacity of institutions in these different areas that I articulated, emphasizing the importance of community engagement in this work. I think that this is an area that all large institutions probably could do better. It's hard work, but it's important if we're talking about long-term systemic change within communities and building stronger local economies. How do large civic organizations, nonprofit and public, be better integrated into their communities? And then leading sector level change, really in two areas we're primarily focused. One is on developing a core set of metrics that we are asking each of the institutions to track and measure in the three areas that I've focused my comments on, as well as is there an opportunity to bring health systems together around public policy agenda that is social determinants of health focus rather than just clinical care. And so that is what we're exploring. We're currently focused on the topic of affordable housing, and I think there's a lot of promise in that conversation in particular. So I'll just briefly pass it on to Sarah to share her perspective in the work that Spectrum is doing, but you can just see on the screen the health systems that are currently participating in the Healthcare Anchor Network. And if you go to healthcareanchor.network, you can learn more about who's participating, some of the articles on the work that institutions are doing, and access some of the resources that we've created collectively over the 2 years the network has existed. Thank you for your time and attention.
Thanks so much, David. So I'm going to turn it over to Sarah. Please keep putting your questions into the chat box, and we'll get to those after Sarah's presentation. All right, there you go, Sarah.
Thank you. So if you didn't notice, Spectrum Health is not currently on the list of formal participants in the Healthcare Anchor Network. So admittedly, I was a little hesitant to speak on the topic today. However, I can say we are doing some of the work that is associated with the Healthcare Anchor Network, and David's offered a lot of phenomenal resources. I think I've worn out my physical copy of the Playbook that he referenced. It's a wonderful resource to help you get started. So where Spectrum Health is today, we're exploring as an organization and really building the business case for why this work is important. And so I kind of want to start there with what that looks like. So we're getting our house in order, as David mentioned. And so I pulled together team members from various departments within our organization that I believe are currently doing anchor mission work. So what does that include? That includes myself. I support our sustainability and our supplier diversity program, and I sit within our supply chain department. It includes our Healthier Communities department, which works within the low income and underserved populations within our communities. It includes our community relations department that does a lot of direct investment in our community and volunteerism. And then it also includes our diversity, equity, and inclusion department. So if you want to go to the next slide, maybe.
Hang on just a second, Sarah. It's not advancing for some reason. There we go.
Okay, so what is the strategic fit? So I started coming at this from the lens of sustainability and specifically looking at the triple bottom line of sustainability. So the way we look at that here at Spectrum Health is people, planet, and prosperity. And so for me, that is the lens by which we do the work, and the Healthcare Anchor Network or Anchor Mission work is offering the specific tactics and strategies that we can utilize to meet this more visionary goal. So what we look at within healthcare is really around human health, and more particularly moving forward, there'll be a much greater emphasis on the social determinants of health. So if you go to the next slide, we talk about the people aspect. So this is kind of how we define things within Spectrum Health, really focusing on our equity work. So Spectrum Health recently identified a diversity officer and created our diversity, equity, and inclusion department as a center of excellence within our organization. So they're elevating that program, and that's important too because of the areas of focus they have within the organization around health equity for our patient population. And supplier diversity is one of their goals as well. They're also looking at workforce diversity because there's some very significant disparities within healthcare for people of color and white patients. And that's not a Spectrum Health statistic, that is generally across the board. So hiring a more diverse workforce is really important and something that we've been focusing on as well as one area that is connected to the Healthcare Anchor Network. Go to the next slide. Oh, and sorry, another piece I wanted to mention related to the people is our Healthier Communities Department. So they do a lot of work in our community around health screenings and direct care to support the health needs. But if you recall when David was presenting, he was referenced a visual of the social determinants of health, and only 20% of your overall health as a person is associated with your access to healthcare and the healthcare you receive when you're in the hospital. So as we move forward from a healthcare perspective, looking at improving the health of the communities we serve, which is our mission, and really improving populations of health, we need to be more creative in looking outside of the direct patient care and how we can look at the economic health of our community, because that really is 40% of how we can help people, and that's part of the hiring of a local inclusive workforce is one aspect of that. So the next slide. One initiative we're working on right now around the planet is opening up a new cafeteria in one of our hospitals and focusing on purchasing from local farmers, from local businesses, and from diverse businesses. So this is a way where we're able to invest our money directly back in our local economy and have more fresh local produce that is high quality, and it's a positive and beneficial approach for our community, but also our patient population and our staff as well, and allows for us to invest directly back into the community. So if you go to the next slide. So it's okay. So the last slide is it's prosperity. So I just wanted to briefly mention some work that we're doing around the prosperity aspect. So right now we have a supplier diversity program. We're spending a little under 4% of our total spend, which is $1.2 billion annually. So 4% of that spend today is with diverse suppliers. And so we have a great opportunity to begin to shift some of our money that is being, that we're using to purchase our supplies and services outside of our community and bring it back into our community. And as the largest employer, you know, I think we have a brand within our community, and this is another way for us to leverage that brand through investing directly back into businesses and having a better relationship with our community businesses. So we are very early on in our journey of supplier diversity. But one example of something that we'll be doing in the next month, we're holding a Meet the Buyer event and bringing out all of our different sourcing departments to an event, and we're asking for community businesses to come and meet with our sourcing departments and learn more about what our process is for going out to bid for an RFP, actually start building relationships between the sourcing specialists and those community businesses, and just increase our transparency and visibility within the community, and recognizing that we really do want to purchase more from local businesses, and we're invested in improving the economic health of our community. So this is one way that we're doing that. Another piece to the supplier diversity work that we're doing, we've partnered with our Inclusion, Equity, and Diversity Department to do some training for our staff. So we've been doing some unconscious bias training and cultural intelligence to help adjust our staff with working with more diverse businesses and making sure that we're feeling comfortable and supported in that work. And so that's one example of how we've partnered with other departments within our institution to leverage the skill sets that they have to better equip ourselves to move forward in this work. And I would say the most important thing to do, well, we haven't joined the network, but as we're continuing to have this conversation and become more intentional with how we operate our business, pulling together the appropriate departments and stakeholders that do the work today to understand where you have opportunity, how you're using your resources today, and what work you may be doing that's overlap with one another. That is really critical to moving the work forward. So if you go to the next slide, what we're really talking about and challenging ourselves as an institution is moving from the contribution to accountability. And this is something that was put together by Kaiser Permanente, but I think it articulates very well as a healthcare organization, reevaluating how we focus on our mission to improve the health of the communities we serve, and not to diminish any of the work that's been done historically, which was very important, but getting more creative with the assets that we have today, both in our people and how we contribute and engage with our various networks, but then our financial resources as well and our purchasing practices. How can we shift them to be more strategic and mission-oriented and more anchor-oriented within our community? So that's some of what we're doing, but we're very early on in our journey, but excited to continue on the work.
All right, so at this point in time, I want to thank both of our speakers, and we will get to the questions in the chat box. So, let's see.
We actually haven't had any questions, Marielle, but maybe we can ask folks to enter them at this point if you have any, or just follow-up thoughts to ask either David or Sarah.
While we're waiting for some questions too, I was wondering, Caitlin, if you would be willing to drop the link in the chat box to the Healthcare Anchor Network in case people didn't catch that.
While people are putting questions in, I'll just maybe add one or two things, which is that the Democracy Collaborative, we're also working on starting up a higher ed network, and we are working with the Coalition of Urban Metropolitan Universities on that. And so we have some 30 universities interested in participating and just working to formalize what that might look like. And the other piece of the work that we're seeking to move forward is around this idea of anchor collaboratives. I believe it's important that there's a healthcare anchor network for health systems. There's a way in which the narrative for this work is more focused on how healthcare can talk about the 30,000-foot idea of anchor specific to their industry, how higher ed can talk about that 30,000-foot specific to their industry, but that there is a space that we're focusing on how to build this idea as a sector for within communities, that there is someone whose job it is, whether it's the local government, whether it's a well-resourced community-based organization, some other nonprofit, or an anchor, a university or a health system that is able to bring together the other anchors within a community to help set shared goals and formalize some process for meaningful collaboration that is more than just transactional arrangements. So that's the aspiration of that third network, which the members of will be mostly not health systems, not universities, but maybe a local government, a nonprofit, or some community-based organization.
Thanks for sharing that, David. So we do have a couple of questions that have come in. So Shayna is interested in hearing more examples of workforce cultivation, the actual strategies behind that outside-in approach that you shared with us, David, from community engagement, recruiting, training programs, apprenticeship, things like that.
Sure. So I think the toolkits we have are actually all 100-page resources. I'm happy to send them out and mail them to whoever is interested in receiving copies. They're also free to download and accessible at hospitaltoolkits.org. And you can go through different worksheets, but one of the worksheets is about identifying your partners. And I think part of this work is for large institutions to recognize they don't have to do this all alone, and that there is a lot of resources that go into workforce development sector in many of our communities, but it's often disconnected from the needs of large institutions that are creating the most jobs. And that part of this is about simply beginning to build that relationship, whether it's someone from a health system or other anchor getting involved in a workforce investment board, identifying workforce intermediaries in your community, thinking about what are the needs that you could bring or help educate those partners on and see where there's intersections of. But then there's even probably a step further, which is in Cleveland, there's a really strong workforce intermediary called Towards Employment, but it didn't have the relationships with the community in order to identify residents that might be a best fit for the program that university hospitals wanted to create. So they worked with a third organization that's called Neighborhood Connections in order to better create a triad of partners that could both connect to residents, be responsive to resident interest, bring the skill sets of a workforce intermediary that could help prepare residents for the jobs of the institution, and university hospitals came to the table about what their needs were. So maybe that sounds simple. I think there was a lot of work that took to make that happen. And then, of course, that's just one model. So I think there's a lot of different ways that can be expanded upon. Hopkins, notably, is one of the few health systems that both prioritizes and takes pride in creating opportunities for returning citizens. And I think that's an important dimension of this work as well, especially as we think about the fact that anchors, as I've defined them here on this webinar, are significant employers in our economy. So how are we not unintentionally excluding folks that are trying to get their foot back into society, coming out of out of prison or some other criminal conviction. So just different ways to be intentional about the opportunities.
The next question is for Sarah from Lindsay. What are some of the challenges you are facing as you're getting started?
So I think this concept of being an anchor institution is kind of like what David was just sharing. It's really a long-term view, and you have to understand that, you know, the work that you do today is not something that you can always necessarily measure today, right? So there's some things we can measure, for example, with our supplier diversity event that's coming up. You know, there's aspects of that we can measure, but it made this relationship building that we're doing between our sourcing team members to kind of socialize the idea of that for them to be more intentional with their sourcing practices is going to take a little bit of more time, and is likely not going to result in a significant increase in our diverse spend in a short period of time. I think the biggest challenge is really understanding that organizationally and moving beyond the operational 12-month cycle of how we view our work oftentimes, and looking more strategically and connecting it to the vision of where we see healthcare in the future and the challenges that we face as we move from a volume-based to a value-based approach, and how this fits in. And then the other, and that really just relates to the competing interests. So one of the things that we've been able to do is really just connect with some of the program areas within our organization that have gained some traction. So the development of our workforce is one of those areas. So continuing to support and grow that while we build from, programs from scratch, essentially, in other areas. So changing the culture has been a big challenge that we've had to face as well. But working with partners across the organization that have a shared vision has been really beneficial, and then pulling on those influencers that can provide a strong voice to the program as well.
Great, thank you. Another question for David, also from Lindsay. How would an organization or health system join the collaborative?
Sure. Do you mind if I respond to that one and her other question down below? But if the leadership isn't bought in the business case piece?
Sure.
So I think actually Sarah started to touch on some of this in her previous comment around if leadership isn't bought in, how would one approach leadership? And I think the strategy that she shared, it makes a lot of sense, building from what is already going on, helping communicate this as an opportunity for alignment, recognizing this, and then also thinking about how this connects the longer term priorities for the organization. On healthcareanchor.network, there is if you go up to the menu bar and you drop down, there's a link to resources. So some of the resources we've built with the health systems in the network, we've made public on that site. So hopefully some of those might be useful, as well as ways to get the conversation started or just begin to socialize the idea. I would also encourage folks to think about unusual suspects or allies within the organization that might be able to help you in this work. I really do think about this as an opportunity for those who have been working in areas that might be seen as nice to do or corporate social responsibility, to think about how to connect the dots more powerfully between all of them, to articulate this as we can be much stronger together if we're aligned and intentional about how these things support each other. And so I think those are just some different ways to begin the conversation. In terms of the business case piece, I think I was talking with a colleague yesterday, and one of the things we were reflecting on is the question of the business case to whom. So I think there is a potential business case to be made for the institution as it relates to its mission for health and well-being, in terms of a shift from volume to value, as Sarah just mentioned. There's also another potential business case to be made if the institution is trying to think about how it relates to local government partners or being a good neighbor. Those are a business case dimension of it, but this work has a different reason for being done if that's the business case perspective. I think there's also another aspect of this, which is what Sarah was describing as Spectrum being one of the largest employers in the region. If you're in a region in which the workforce is getting older or shrinking, long-term viability of your institution is at risk. So there's a need to come together around a broader agenda. So there's the narrow business case of the bottom line as it relates to, is this something we want to reimburse for long-term versus, the larger region conversation that we sit in as a large employer. That said, I really do believe at the core of this work that none of those on their own are powerful enough to say we should stop doing what we're doing today and do something different. That there really needs to be something compelling from your local situation that helps people realize that what we're currently doing really is not working. It's not leading to to protecting the three things that Sarah talked about: people, prosperity, and planet, and that we need to think about how to do that better while also recognizing the constraints in which we are in terms of resources. Just lastly, in terms of a health system joining the joining the Healthcare Anchor Network, there's an annual fee and there's a commitment to tracking the data and participating in the initiative groups and the convenings and the other collective work of the network. So in short, that's the ask, but hopefully the network is serving as a platform to further mainstream this idea and approach within the sector as a whole.
I would agree with everything David mentioned, and the only thing I would add, so as we pulled together our team, our work group that's really reflecting on, well, what have we done? One of the things we've heard is, well, we're already doing this work, which in some regard is true. So we took that and we decided to dig into it and say, okay, well, how well are we doing this work today? And then we started to pull together and evaluate, how are we using our assets as a core team today, both our volunteer time, participating in outside organizations, our direct contribution, financial contribution to outside organizations. So how are we really impacting our community today? And we looked at that, and then we compared it to our community benefit and how much money we're spending today with providing care for patients because they can't afford to pay. They don't have insurance and can't afford it. And we looked at how much money we're spending on that kind of care versus how much we're investing in the preventative medicine, if you will, or the preventative measures through economic health initiatives of this group. And it was a tiny percentage, less than 1% that was working on the upstream preventative approach, which is what this team is working on today. So that is really insightful to have a conversation with your leadership and understanding, like, what are you doing today, and how can you be using your resources more effectively in the future? So it's not even about, asking for more of anything. It's about how we use them today. And are we doing a good job of that?
Thanks both for your answers on that. Can you speak a little bit about the relation of this work to the ACA Community Benefit? You started to mention it, but it'd be good to hear a little bit more about that.
So are you talking about like community benefit reporting? All nonprofit hospitals have to give back to the community in order to maintain our nonprofit status. And so that's something that you can look up, and you can see Spectrum Health. If you go to our website, you can see our community benefit and how much of that we do today. And moving forward in the future with different payer mixes that could potentially change. For example, charity care is sometimes what it's referenced as, but that's for patients who can't they can't pay for their care today. And so that's what a majority of our community benefit is. And it's not just Spectrum Health, that's across the healthcare industry. So if the payer mix changes in the future and we have less of that charity care, how will we continue to maintain our nonprofit status? And so looking at other ways to give back and invest in the community is a way to potentially, expand upon that. But I think it's important to mention, I think the greater aha moment that we had when we were sitting there and realized it was really impactful was how much money are we spending today on preventing some of these long-term health ailments of our community, and knowing that 40% of your overall health is determined through the economic health of your community, and specifically those marginalized groups. So that's really been more of what we're kind of focused on, but also knowing that charity care is likely going to be something that's going to continue to be reduced.
The only thing I'd add to what Sarah shared is that I think of the ACA Community Benefit, and more importantly, the Community Health Needs Assessment, less as a requirement that would make health systems do this type of work, rather than, instead, I think of it as an opportunity to help change the narrative. Just in the same way that I was referencing that there's often something within the local context that gets people who haven't recognized that there's a problem going on to say, oh, that's just not right. And so just as a quick example there, ProMedica's journey for its anchor work really starts with it thinking it was going to do work around obesity in the schools, and then recognizing that hunger was what was showing up as the problem. And it saying to itself, people there saying, well, we didn't sign up for hunger as the challenge we're seeking to address as a health system. But that's the conversation that got started. And I think, at the end of the day, our institutions are made up of people. And it's really about how do we put front and center the really difficult conversations that we need to have about the systemic challenges that are showing up in our community to help think about how we pull together more powerfully to address them. And I think you can replicate that story in most of the communities where anchors are getting involved. And in some places, it's recognizing there's a huge disparity between two groups, or others, it's recognizing, one place where we did work, Amarillo, Texas, they have 3% unemployment, but 90% of kids on free and reduced lunch. And that just flies in the face of the narrative that we have in this country of if you work hard, you can get ahead. You shouldn't need to be supported. And so there was a recognition that something needed to be done around the quality of jobs. So I think that there are different ways to get at this for different audiences, but it really does start with your local context.
Thanks both. So we are coming up at the end of our hour together. Any final thoughts from either of our presenters? Any words of wisdom for those thinking about the idea of anchored institutions, or any tips and tricks you might have to share?
No, I think David covered it. Really understanding what the true needs are of the community, rather than assuming it, would be the number one most important thing to do. And then making sure that you have the appropriate stakeholders involved and engaging the right people from the start.
Well said.
All right. Well, I want to thank David and Sarah again for taking the time today to share their work with us. We really appreciate, and I hope everyone that joined us today got something out of the presentation, and thank you for spending time with us this afternoon. Have a good rest of your day, everyone.
Thank you.
Thank you.